Leadership support for culturally competent care among first responders and healthcare workers. First responders and healthcare workers begin their careers in top mental and physical shape. However, the demands of these frontline jobs take their toll and can cut careers short, affect job performance, which adversely affect those we serve, damage relationships with colleagues, family, and friends, and even take lives. This presentation addresses how stigma about substance use disorder and mental health disorder affect us, how help seeking is vital to survival and appropriate self-care, and operational efficiency of the unit and what measures are effective in promoting these cultural changes. As defined by the American Hospital Association, cultural competence seeks to provide care for patients who exhibit a variety of values, beliefs, and behaviors by tailoring their care to meet their social, cultural, and linguistic needs. The AHA also recognizes that every patient is different. They have different experiences, different attitudes, and different perceptions, particularly when it concerns clinical care. By increasing our ability to provide culturally competent care, we increase our rapport with those we serve, promote earlier help seeking, and better outcomes. Reeder et al. In 2021 found that culturally competent care has two major components: cultural competence and avoiding stigma. Stephanie Kanak writes that stigma is anything that marks an individual as being unacceptably different from the quote-unquote normal people with whom he or she routinely interacts, and that elicits some form of community sanction. Stigma reduces physical and emotional well-being, prevents seeking care, and reduces health outcomes. If you have an identity that society values negatively, you are said to be stigmatized. People experiencing stigma are often made to feel like outsiders and usually experience hurt, exclusion, and marginalization due to various differences. Stigma occurs both in conscious and unconscious ways about race, gender, sexual preference, a range of mental health conditions, socioeconomic status, religious preference, skin color, disabilities, and substance and opioid use disorders. Reeder et al. Assert that culturally competent care also includes avoiding stigma associated with disease status, mental or substance use challenges, sexuality or gender identity, race or ethnicity, or minority religious affiliation. Dr. Kanak, writing in 2017, tells us that people who experience stigma present with worse overall physical and emotional well-being, are less likely to seek care, and exhibit worse health outcomes when they do receive care. Corrigan and Watson found that those with stigma related to their mental illness are seen as others, perceived as dangerous, seen as irresponsible or unable to make their own decisions, are less likely to get hired or promoted, and less likely to get safe housing. They are more likely to be criminalized than offered health care. In other words, they're more frequently put in the squad car instead of the ambulance, and so afraid of rejection that they don't always pursue opportunities to help themselves. Stigma plays a large role in why we don't provide culturally competent care for ourselves, for those we serve, and for each other. A belief that most folks in a group have similar characteristics, even when the characteristic is outwardly positive, like being good at math, is called stereotyping. Grouping people as being similar without knowing if it is factual leads to errors. You can read some common ones here, but think of some group regarding the people you serve in your profession. Are you grouping people by age, health condition, or race, and assuming that they share some common trait? That is stereotyping. If stereotyping is only a belief, then why does it matter? Because stereotyping plus discrimination and prejudice combine to deny the care, service, and support we dedicate our careers to provide. Let's define bias and stereotype. A bias refers to a personal preference that interferes with the ability to be impartial, unprejudiced, or objective, while stereotypes are preconceived ideas that certain attributes apply to all members of a group. What is the difference between a bias and a stereotype? If you hire an Asian person instead of a black or white person who are equally qualified to fill an IT position because you believe the Asian is quote unquote naturally smarter, you're demonstrating a bias, which may be based on a stereotype. However, if you believe all cops like donuts, that's a stereotype. Because stigma causes so much damage, we're going to investigate it more closely. A researcher in Canada, Dr. Kanak, has identified 3 types of stigma. Interpersonal stigma, which can also be called self-stigma, is the feeling that you're not worthy of treatment because of your condition. For instance, opioid use disorder, what used to be called opioid addiction or a mental health disorder, such as depression or PTSD. Because, as Dr. Kanak reports, this self-stigma results in people with substance use disorder or mental health disorders from seeking help because they don't want to disclose the issue to someone else, or because they have come to believe that the condition is hopeless or untreatable. This can lead to tragic outcomes such as death from suicide and overdose, but also to unnecessary lack of treatment for our colleagues, for those we serve, our patients, and for ourselves. Interpersonal stigma is the type of stigma we feel towards others, including our colleagues, citizens in our community, our patients, and our family and friends. These common stigmas result in less access to care, criminalizing behavior, and restriction of access to community-offered resources. Structural or systemic stigma is a result of policies, laws, and systems that exclude or discriminate in open or hidden ways that prevent equal access to resources. This type of stigma can be based on the color of the pigment of your skin, your level of educational attainment, your financial situation, the way you dress, your sexual or gender preferences, and many others. As you consider systemic stigma, think of a location in your work environment where it is difficult for someone in a given class of people to easily and respectfully obtain the services that you provide. Stigma is frequently found in our squad rooms, ambulance bays, firehouses, emergency rooms, and employee lounges. As our professions have become aware of the costs of stigma, we are all trying to address ways of confronting it with leadership in interpersonal, intrapersonal, and systemic ways to prevent the inability to openly address psychological problems or substance use disorders experienced on the job or at home. This combats the mistaken beliefs that mental illness makes you less competent, more dangerous, and unpredictable, and that being at work somehow isn't beneficial for those with a mental health disorder. So, Dr. Kanak found that for frontline workers, stigma results in an unwillingness to seek help, an unwillingness to disclose a mental health or substance use problem, an over-reliance on self-treatment, lower levels of peer support, including ostracization if public disclosure occurs, and an increased risk of suicide. Let's dive into bias a little deeper. Biases are assumptions, that is, beliefs, that aren't correct we make about someone or our group, as we stated before. These biases are basic actions our brains take when making decisions, often below the level of conscious thought, that cause us to have an affinity for, that is, to like or prefer, people who are similar to ourselves. Everyone has biases, and they are believed to be a survival instinct that causes us to seek out people similar to ourselves because our brain innately sees this as safe. While everyone has biases, not everyone has to act without thinking about their biases. Bias can be either conscious, where you purposely discriminate against someone, or in a more subtle way as caused by implicit bias, which is often hard to know about yourself. Studies have shown that at least 2/3 of health providers hold some form of implicit bias against marginalized groups. What can we as first responders and healthcare workers do to address stigmas, stereotypes, and biases? In this next section, we'll cover some methods and techniques for dealing with stigma, stereotyping, and bias to prevent the negative outcomes these issues create. As first responders and healthcare workers, we're all taught the basic components of fire somewhere along the way. The basics state that fire requires fuel plus oxygen plus heat to burn. Stigma has requirements to cause harm as well. Stereotypes, that is, ignorance or false beliefs about a group, plus prejudice plus discrimination. These elements of stigma combine in hurtful and harmful ways that prevent us from helping those we serve and care for, including our colleagues, while they are addressing trauma, substance use disorder, and mental health disorder that lowers the quality of our lives. Now we need to recognize the contributory factors of stigma so that our fellow first responders and healthcare colleagues get the help they need to prevent the consequences of unresolved mental health and substance use disorders. How do we combat stigma? Bedford has outlined some methods to combat stigma that as leaders or followers we can promote and subscribe to. First is recognize stereotypical thinking in ourselves and others and point it out. Next, replace biases and assumptions. Be thoughtful about decisions. Examine the risk of an implicit bias affecting your decision making. Understand the individual. By putting yourself in their shoes, see the trauma or illness from their point of view and help them understand how you can help and what you can do. Explore a new perspective by placing yourself in an environment that is outside your comfort zone. Establish new relationships. Increase positive contacts with different races, sexual orientations, and genders. Folks with mental health disorders and substance use disorders that allow for an open discussion of how to interact to prevent bias, stereotyping, and stigma. To overcome bias, Bedford continues by outlining some strategies that have helped. And one of the most effective is the person-centered approach. Use person-first language. For example, instead of labeling someone as an addict, say, a person with a substance use disorder. Recognize stereotypical thoughts as they occur and discount them. Use self-reflection to recognize stereotypical thinking, such as all people have some characteristic, and then trying to focus on an observable or provided characteristic that the person themselves gave you. Instead of relying on assumptions, you must train yourself to focus on the individual as your primary source of information. Use the person under consideration as the source of information, not your preconceived impression. Another strategy is to compensate for your implicit preferences. For example, if you have an implicit preference for young people, you can try to be friendlier toward elderly people. Friendliness towards someone you have a bias towards is a good tool to modify your behavior. Another good tool is watching television programs and movies that portray women and minority members in a positive or counter-stereotypical way. Investigate groups you consider to be other on TV or on YouTube to understand their perspectives and points of view. Keep it up. Overcoming bias is a lifetime effort which requires constant work.